Jackie, honey, it is such a pleasure to have you here on the Energize podcast. How are you doing today?
Awesome. Thank you so much for having me. I appreciate you having me here to talk and doing great. Can't complain.
I love it. I love it. Well, first question I want to ask out the gate, because I've just fallen in love with your authenticity. I can just tell you're so heart centered. Like I immediately, when I started following you on Insta, and can you just share your Insta handle right out the gate so people can just go and
Yeah, of course.
get it?
Yes. So I started this crazy Insta thing a little over a year ago. Jackie P underscore GYN, which is short for gynecology NP. So GYNNP, that's me on Insta. So come find me, come follow me.
Yes, and we're going to have it in the show notes, so you guys can go and grab that right now. But I started following you, and I loved the realness, the authenticity. Like I knew you were heart driven, and so I've always been curious to know kind of what was that defining moment that had you focusing on women in midlife, perimenopause, and menopause.
Yeah, I always said, so it's so funny whenever I get asked the story, because I always say perimenopause and menopause really fell into my lap as a clinical provider. I had just gone an entire year staying at home with my daughter and had my second daughter. And I really was sort of desperate to sort of get back into the workplace, which I think sort of is interesting how it parallels perimenopause and menopause, because we see so many women struggling with certain kind of, executive functioning things about kind of their life. And I was really struggling being a stay-at-home mom and having gone to NP school and really wanting that part of my life back. And I was offered an opportunity to work with a gynecologist just one day a week and sort of get me out of the house and working again. And it was around perimenopause and menopause, and I thought she was crazy. I had a long career in OBGYN, basic OBGYN as an NP for several different practices prior to this job. And I really was like the rest of the clinicians that I sort of give a hard time on my social media space. I didn't really treat women in midlife appropriately. And I probably am guilty for gaslighting them or not hearing what they were saying and not fully grasping and understanding. So I took the job just on a whim to sort of just get my feet wet again as a clinician. And it doesn't take long when you're a clinician in the perimenopause and menopause space to fall in love with the change that so can happen in these women's lives, and just how much better people can start feeling and functioning, and just the overall impact it has on their entire lives. It's the patient, it's the people that I was caring for. And the physician that hired me, she said, I know it sounds crazy, Jackie, we were not taught to do menopause and perimenopause, but just trust me and listen to these women. And that's what I did. It was that leap of faith. And sometimes you just kind of get called in a direction, and I went with the flow. But yeah, 8 years later, bucking on.
I love it. Oh my goodness. And are you in, I know you're in your own practice now. Are you still working with OBGYN or just doing your own thing as well?
Yeah. So a little over a year ago, I totally broke off on my own and started my own little niche practice. It started out primarily, or almost all telemedicine. One of the silver linings of the COVID pandemic is it gave us telehealth. And so I have licenses in several states. And then I recently, within the last 6 months, opened up a brick and mortar suburb of Atlanta. So I see patients in Georgia and some other states as well, in just a little micro niche midlife women's health clinic.
I love it. And then just from a personal perspective as well, I know you have 2 little girls, beautiful girls, and you're doing that. You've got this mission, you've got this purpose. How, and I don't know where you're landing on kind of in the spectrum of this beautiful journey as well, but how is that all? How are you? I wouldn't call it balance. I don't ever want to say that we're balancing anything, because honestly, there's no such thing. But how is that working for you? How are you figuring that?
Gosh. I am not a role model for balance whatsoever. I will fall. I'm probably an individual that will fall and dive headfirst into work and keep my head down and work. And I sort of have to pull myself back out into motherhood and like take that breather and say, okay, slow down, get back to it. So, I am fully transparent. Motherhood does not always come easy to me. Like working in my job is something that I think I do relatively with ease. I enjoy it, and I think that maybe, like you said, that shows. But balance is hard. I'm constantly sort of trying to do the practice what you preach, because it's so hard. We wear so many hats as women. We're juggling so many different obligations, and the word no doesn't always come easy in our vocabulary. So again, I am a work in progress, probably like many of the women that I see, and maybe that helps. I think it helps. It's good to be relatable to as a person with certain levels of influence, to be somebody that other people can see themselves.
That's why I wanted to ask, because I know so many of my audience members are mamas, right? And they're doing the best they can with what they've got. They're going through perimenopause and menopause, right? Menopause for all of us is inevitable, no matter how we get there. And it is such a crazy ride. And so many of us are, depending on how old your children are, we're all just kind of juggling this. And there's nothing more profound than the remodeling of our brain during this process. And I just wanted to check in with you and just, kind of see how you're navigating it all as well.
Yes, 100%. And, there's been really great data that's come out just within the last 2 years to show, I mean, we've had data before this, but really more an aggressive approach to the data and just how the vast majority of the symptoms, we historically always sort of stereotyped these symptoms of perimenopause and menopause as hot flashes, right?
Sweats.
And if you don't have hot flashes, then you're not experiencing menopause and perimenopause. But we actually know now that the bulk of the symptoms are actually derived from the brain. So just like a hot flashes too, it's coming from the hypothalamus, the temperature regulation center, loss of memory, concentration, focus, motivation, low mood, just brain fog in general, cognition. I have women say, I feel dumb. I just feel like, and I hate that. They just feel not themselves and something's off. So really important, I think, to shift the narrative and get away from some of these kind of older narratives of what menopause looks like. And it's actually funny that I love that you kind of asked me the real mom question. And women have so many hats and so many things to juggle, and so many women are going through the experience of perimenopause and menopause while raising a family. And I gave a talk actually 2 weeks ago to a group of infertility specialists and infertility nurses. And this population, the average woman that goes through an infertility practice is 37 years old. And this is the kind of the time frame where we are really starting to hone in that a lot of women are starting to experience these symptoms in their late 30s, early 40s. And the whole sort of tagline of my talk was, don't start building these families and then leave these women hanging with this sort of elephant in the room of this perimenopause, and you have this beautiful new baby, but don't let perimenopause spoil it and undo their ability to enjoy other aspects of their life. So it's really important that we take a holistic view of women's health and bring it full circle.
Yeah, I mean, I had my son at 41. So I was in it.
Yeah, you totally were 100%.
And, postpartum is its own journey. Postpartum and perimenopause is a whole nother beast. And I remember at 43, after ending my breastfeeding journey with my son, and abruptly because of a couple of major concussions, but I felt like I got drop kicked into perimenopause. I went from one level of hormone depletion into another level of hormone depletion. I was like, goodness. And I'm curious, the research, I'm so fascinated around this particular demographic of women who are having babies in perimenopause and like how that plays out for them, mostly so selfishly interested for myself. But also that there are so many of us having children in our late 30s, early 40s, and kind of how does that play out for us, heading into peri and menopause?
We really do see that generationally speaking, like millennials have delayed childbearing. And probably the generations, I mean, we've seen big Fortune 500 companies offer egg freezing and fertility preservation as part of the health insurance plan that you get at your job. And so women are delaying that. And it really is, I mean, these hormone fluctuations can be massive. Actually, interestingly enough, the postpartum hormone event, so the day that you give birth and then the day that you're postpartum, is actually one of the, if not the largest.
Yeah.
It is the largest. I don't want to misquote because I didn't track for this exact statistic.
Sorry, but I know.
That's okay. But I actually teach on postpartum hormones, and so I'm trying to dig out from the back of my brain here. But it is the largest hormone drop in a single sort of span of time in a woman's life. And then, typically speaking, now breastfeeding kind of adds another layer of hormone suppression to it. But typically the brain can actually, in the vast majority of women, it does rebound. And the degree of time that it rebounds from that postpartum incident varies. But if you are a particularly vulnerable individual, and we have identified that there may be actually a phenotype, and a phenotype, if you're not familiar, is an expression of a gene. So I think your eye color is a phenotype. But we know that there may be a phenotype or somebody that is particularly vulnerable genetically to these hormone fluctuations. And they're going to be your individuals that tend to have these severe postpartum depression, severe mood changes with that hormone change. But then if you look back, they actually likely are those individuals that struggled with PMS and PMDD during puberty and during the introduction of their hormones and their ovarian function. And then actually, I just had this conversation yesterday with a patient. She actually had severe postpartum anxiety. And what was her primary symptom in perimenopause? Severe, debilitating anxiety, irritability. She said she has absolutely no chill, and that her husband bears the brunt of it. And that's distressing to her and her whole family. It's impacting her entire household. And so it shows this vulnerability. I sort of say it's like,
Yeah, it's a litmus test.
yes, when you go see a cardiologist and they put you on a treadmill and they say, here's your stress test for your heart. I mean, it's truly a stress test. These hormone changes and events in our body are stress tests for our brain. And certain people are particularly vulnerable to having a more debilitating experience than others. I think women, just generally speaking, knowledge is very abundant via social media. We have the internet. The internet looks nothing like it did when I was in high school. It's changed.
It
right?
almost didn't exist when
Yeah,
I was
it
in high school.
didn't exist. AOL dial-up, yeah.
Yeah.
I mean, there was nothing. I mean, we still had to go to libraries to do.
Exactly.
And so women have so much knowledge at their fingertips. And I think just the general awareness around their body or something just doesn't feel quite right. The barriers to entry or the access to information is not so far away. And so we can start sort of maybe piecing things together. And then unfortunately, we try to take that and rely on our standard medical practitioner to sort of help us pull that all together. But we see this huge gap of knowledge in the medical space regarding this time, the perimenopause and menopause time. I would actually argue more of a gap in knowledge in perimenopause than even in menopause. And women are just sort of left to, figure their way out through the dark, and try not to stumble and trip over too many things.
Yeah, I agree. I mean, I think not only postpartum, but even pregnancy, both are a stress test to kind of see how it's going to play out. I always tell people I didn't pass pregnancy. I ended up getting early stages of preeclampsia. And there's a lot of cardiovascular issues in my family. My sister, who's younger than me, had a stroke last year. And so when my blood pressure got too high, I ended up having to get induced at 39 weeks, which I was pretty much at the finish line. But it was very much something like I put a pin in it. I was okay. This is something that needs to be on my radar. If I didn't pass this test, I got to keep a sharp eye on my cardiovascular numbers moving forward. But rarely do we hear these. We have these conversations. If women have gestational diabetes, in pregnancy, or again, high levels of anxiety and depression and early postpartum, we're not saying, hey, this is maybe something to look. We just keep an eye on this as we head into that powerful transition, that remodeling that's going to happen.
Yeah. Well, and traditional medicine is really good at reactive care. We're really good at doing this thing where we call, we're just going to watch this. It's like, I always tease and say, well, what do you mean we're going to watch it? We're going to watch it do what? We're going to watch it get worse. Yeah. Yeah. And so I would actually argue, and I might actually get some pushback for this, but I would actually argue that a woman who has just given birth, who is immediately postpartum, that is likely not the best time in a woman's life to actually try to actively impart massive preventative measures. And I don't mean that by saying, okay, we give up on a woman and say, oh, she shouldn't, take her health into her own hands. It's just that her focus, almost always the singular focus, is going to be on that newborn. And it's totally,
we're rewired for it.
So when you have a woman, and this is kind of where I'm going with it, if you have a woman who has gestational diabetes, she is focusing on gestational diabetes for her own health, but primarily for the health of that baby, to get that baby out and to be as healthy as possible. But then when you visit with a woman who has gestational diabetes, the statistic is 60%. It may actually be worse now because we have such an obesogenic environment, but it smells, the last time I quoted it, it was 60%. So meaning 60% of women who develop gestational diabetes, or they fail their stress test, their blood sugar and metabolic stress test in pregnancy, will develop type 2 diabetes later in life. But if you tell a woman that postpartum, chances are it's going to go in one ear and out the other, because the singular focus is on the infant. And what we're not doing is when that woman comes in for her well woman exam or whatnot,
or an annual exam a year later.
And a year later, or say she's 45 and she's coming here, we're very good about giving prescription for breast prevention, or even now colorectal screening prevention, right? Colonoscopy should be starting at 45 now, mammograms at 40. We are not good at offering cardiovascular and cardiometabolic prevention for women. We still, the vast majority of medical practitioners out there are telling women out of date information. They're telling them to eat less, move more, which does not work. It is completely, most women are already doing that.
And that's not helping them.
Correct. They've done years of yo-yo dieting, calorie deprivation. They've completely messed up their body's metabolic inner working. We live, like I said, in an obesogenic environment, meaning our environment, it promotes us to store fat. So what we're not doing is we are not preventing that. So we might check a lipid panel, a cholesterol panel. Your cholesterol's a little high. Okay, let's watch it. We're not sending them to a cardiologist for a baseline assessment. Heart palpitations are some of the most common symptoms, one of the most common symptoms of menopause. And oftentimes they start in perimenopause. Oprah's famous for saying she met with 5 different physician cardiologists, and they're the best cardiologists in the U.S., and none of them diagnosed her with menopause. I think it was her gynecologist, Dr. Sharon Malone, who did. So that's my biggest thing. When I get my hands on my patients, like, where did you have a baseline cardiac assessment? Have you visited with a cardiologist? And it's almost like, no, I would never even think to do that.
I know. When it's the number one killer of us, more than men.
100%. And we now associate degree of symptoms in perimenopause and menopause with actually degree or potential future risk of developing severe disease, particularly cardiometabolic diseases like insulin resistance, fatty liver, heart disease, diabetes, those sorts of things.
I'd love to talk a little bit about that. And I'm so grateful. You're right. I was so grateful to know this. The second I had preeclampsia, I was like, ding, ding, ding. Like, it was not on my radar at the moment, but I was like, okay, it's on my radar in general. And I think that general knowledge, us having this conversation of just saying, okay, this, I need to put a pin in this. This is something I just get to tend to. And again, cardiovascular disease is the number one killer of us in general. So I had a pin in it, but I knew that I was a little bit more, kind of fragile to it heading into perimenopause. I do want to, and that's why metabolic health, I think for me, has been such a big part of my work in my journey with my patients, is I want to keep an eye on that, where women are thinking, well, I don't have to worry about this until I'm in my 60s, until things start to really shift. I want it to be on our radar in our 40s, because that's when I see things actually shift. And so I'd love to speak into that, into what I call, you and I both call kind of the metabolic trifecta of, what happens in midlife, and much earlier than I think a lot of us realize. We start to see these kind of what I call subtle symptoms of metabolic syndrome, well before they become overt, well before we see the high blood pressure, or the fasting blood glucose or triglycerides above 150 milligrams per deciliter. We start to see these subtle signs and symptoms. So I'd love to speak into that, if that's feeling alive for you at the moment, because I kind of go in that direction.
I will tell you, probably the most common symptom that drives a woman into my office is going to be around their metabolic health and around stubborn weight gain. And the vast majority of them, dare I say all, have already utilized the tricks of the trade that we have always sort of subscribed and thought were the right things to do. And they're coming up empty-handed. Sometimes it's because their hemoglobin A1C went up. for no good reason other than they got a year older.
They lost
And
some
so,
hormones.
yeah, they are exactly. They're out to lunch for sure. So typically, what we see, and a lot of women don't know this, is that we actually start losing our muscle mass in our 30s, and that happens, so much younger than I think we typically associate with the menopause transition. We associate it with our 50s, our mid 50s, even. And this losing muscle mass is a huge component of the metabolic shift because that loss in muscle, I've heard other people say muscle is the organ of longevity.
Yeah,
And
Esty,
Yazesti.
Dr. Lyon.
Yeah, Gabrielle Lyon. That's her. Yeah, Gabrielle Lyon. Oh my God.
That's her tagline.
Her book is like,
Right there.
yeah. Anywho, it's so important for women to recognize this because the vast majority of women have also spent their entire life on a treadmill or an elliptical machine and not in the weight room lifting weight. And it's this total shift from not eating less and moving differently, eating more actually, just differently, and moving in a different way, not necessarily more. I would say work smarter, not harder. And so that really starts to occur. Then our cells start to change. So our cells develop insulin resistance. And this happens for a number of different reasons. But part of it is the changes in our female reproductive hormones, our sex hormone. Our cells respond to a hormone called insulin, which tells our body how to utilize energy and what to do with it. But if we have a resistance to this, we accumulate levels of insulin, which then stimulate our appetite and tell our body that we need to store things as fat. And so I kind of use the analogy with my perimenopause and menopausal patients, and I'll say your body is in a state of depletion. And it's almost like looking out your window during the fall and seeing the little squirrels go and finding every little acorn they can possibly find to store away for a rainy day. And we need to sort of get your body back so it doesn't feel like winter is coming. We need to build muscle mass and actually work proactively towards positive metabolic health rather than trying to just constantly be the salmon that's swimming upstream that just is working so much harder to get no result, negative results. And that's when it gets really, really frustrating. So there's many, many different layers of what's happening. But insulin resistance is a key component. And oftentimes this is seen it is first recognized because most practitioners are not checking the fasting serum insulin level. It is seen in the hemoglobin A1C, which is my favorite analogy. I'm an analogies person if you can't already tell. It's kind of like your fasting serum insulin is, like the smoke that's billowing under the door. A hemoglobin A1C if the house is already burned down, pretty much. It is too late to call the fire department at that point. These metabolic changes have already set in. It's going to be so much harder. Now, of course, we have amazing therapies that have come on the market in the last, 10, 15 years to help with this, but it's so much easier to get ahead of it and make these subtle shifts work smarter, not harder. But you just have to know what to do.
Agreed. Yeah. And I agree with you 100% wholeheartedly. Not only are we losing muscle, but we're losing strength in our 30s. So by the time we even walk into our 40s, we're choosing things that, don't require as much capacity, to some degree as well. So yeah, we're not lifting the heavy things, and I know that insulin resistance starts in the muscle, and that's kind of where the problem begins. And if we're only looking at an A1C or fasting blood sugar level, it's just not going to ever give us the full picture. I tell people at the very least, when you run that lipid panel, just at least divide your triglycerides over your HDLs to give you a score. If your doctor will not run that fasting insulin, and I'm looking for a ratio of 2 or under to be optimal.
I agree. Yeah. Yes, 100%. Such a good predictor of cardiometabolic health. Another really easy thing that women can do is measure their hip and their waist circumference. And, that's with a tape measure that you can get at, the craft store. And there are easy little calculators that you can Google and put that in, and that will tell you what happens there. But another concept too, before we move on from this is, and we sort of touched on it before, is that we're just underfed. I mean, the vast majority of women that I speak to are not consuming enough protein. So we're losing muscle mass, and then we're not able to sort of get it back or gaining muscle is a task. It is,
You got to work for it. It doesn't
you
come
have
on
to,
easy.
it does not. So you can't, there was actually a personal trainer, I think on Instagram, that was like, did some video that made me laugh because she was like, do you think you could just walk into the gym and get bulky? How dare you assume that it would be that easy? This takes work. So many women are so worried about the concept of strength training, changing their body to something that is not, aesthetically pleasing for them. And it's quite the opposite. We are oftentimes overfed, so we're not even consuming enough protein to build muscle mass. And so it's, again, just making little changes in your regimen and make a huge impact on your current state of health, but also your future state of health.
So two things we're walking away with, and my ladies hear this all the time, but I want to just really quickly put a pin in it. One, that we get in the gym, lift those weights. Number two,
put it down.
Is lay down that protein. A lot of women in midlife, we're lots of extra cardio, a lot of calorie restriction, and that's not helping us to combat the insulin resistance or the loss of muscle or support our metabolic flexibility. Any other things, Jackie, that you find are kind of game changing for women that are lifestyle, right? And I get that there are medications on the market as well that can help kind of mitigate some of this. But at the end of the day, I think it's the consistency every day. Like the personal trainer said, she's just like, are you kidding me? Muscle is earned.
Yeah.
It doesn't I wish it just came on. I bust my butt every day to build muscle.
I hear you. I know. My husband always says, he's like, I have to go feed my muscle children. Like, he's such a goober. I know. Right?
We talk about our microbiome. We call them tummy bugs. I never thought of muscle children.
He's always like, I have to feed the muscle children. But anywho, this is what I'm going to say, and it may sound super easy, low-hanging fruit, but I love low-hanging fruit. I love that low-hanging fruit is attainable. You need to prioritize and guard your sleep with your life. Your sleep.
Yes.
And this goes in again to back to I put something on Instagram the other day that was like, I'm up all night coughing, so I might as well be staring at my phone, nothing with my blue light cortisol regulation number. But yes. I had so many people DM me and say, my God, Jackie, thank you so much for putting that there. It's so relatable. Like, thank you for being on it. Because social media oftentimes what they say, like the highlight reel, like everything has to be so perfect and buttoned up. And I try not to be that way on social media because I'm anything but that and buttoned up. But you have to prioritize your sleep. Put your phone away. But just put, if you're going to have your phone, have it do a walk you through a guided meditation.
It's away over there.
Relax.
Hear it.
Yes. Rain sound, guided meditation, whatever it is, something that is going to actually work for you rather than against you. But sleep is probably the number one thing that you as an individual have full and utter control over. I mean, if you are a shift worker or whatever, there's of course special circumstances there. If you have a newborn, there's certain things that are going to that. But for all other intensive reasons, working on your sleep is going to give you so much bang for your buck. And if you can invest in a device, a wearable that actually will give you some data points about your sleep. There's actually a cool one coming out. It's an earring. Have you seen this?
No, I'm a big earring, Oop and Aura, but I haven't heard of the earring yet.
I don't know the name of it, but it's just the algorithm is feeding it to me. But it's an earring, and it actually I think was meant to track menstrual cycle, but it's going to track some other biomarkers. But yes, I love the ring. The ring is easy. I wear my watch, but it's really nice to kind of see that you're making some progress. Some people are reward based, and sometimes that can be helpful. But sleep is low-hanging fruit, and is my favorite.
I would love to talk because I know some of my ladies would say, but I am doing my best to get it. And I always say, put your sleep like it's $1 million meeting. Shut it off.
Oh my God, I love that.
Shut down your partner if he wants or she or he wants you to go to bed. It's shut off Netflix. Don't let them interfere. Like, protect it. I'm like, if you're not $1 million meeting, you don't get to come in, and so, but I have a lot of rituals. I have a lot of things that I literally kick off an hour before with a couple of supplements, and that is the kickoff. Like, nothing nothing stopping the sleep brigade, and so I'd love to hear, because I know so many of, I think 65% of women in peri in particular in midlife, we start to have these major sleep disruptions. One, I think a lot of it has to do with life and the fact that we're moms and there's so much that we're holding. We just barely got the kids to sleep, you know what I'm saying? And so, but also it's hormones, also it's metabolic health. Maybe it's blood sugar crashes. There's a lot of things going on there, or circadian rhythm disruption. Are there some things that you have found to be tried and true for your ladies who come to you and you're just like, I've tried. I can't get to sleep. My stress won't let me. My trauma is peaking up at 10 o'clock at night.
So, I really like to come at this from two different sort of approaches and schools of thought. There are some excellent things that we can utilize in complementary alternative medicine. I mean, sort of beyond just meditation and sleepy tea and sort of just
a hot bath that nobody
a hot bath. Yeah, exactly. So this is, and of course, this is generalized information and not specific medical advice, but my favorite supplements to utilize are magnesium. Particularly, there's a couple different forms of magnesium, but magnesium glycinate is really relaxing and actually can help promote, nice bowel movements too, and it helps relax the muscles in the joints and also helps with sleep. And then magnesium L-threonate. So magnesiums are bound to these amino acids, and that's how they're delivered in the body, and they have different effects throughout the body, just depending on which amino acid that they're bound to. And so magnesium L-threonate is actually more cognitive. It works more in the brain. And I actually take a combination. I take one glycinate, one threonate. Some people take the Cahill. There's different companies that have different ones. And then there's another amino acid that I use called L-theanine, which is a calming supplement. So that can be very useful. There's other things like valerian root and chamomile and different things. Obviously, consult your medical practitioner before you try anything. And then melatonin is one that some people use. I am one of those weird people that gets horrific nightmares with melatonin. So my husband loves it. I cannot take it. But there are good nutraceuticals out there that you can use.
I love those. I love all those suggestions. I love holy basil tea too, if it's adaptogens that you could help support. And then with melatonin, one of the things just to note is that it drops along with progesterone and estradiol and peri. Some of us, we really do benefit from maybe 3 to 5 milligrams, but others, depending on phenotypes, how our brain is functioning, some of us are just very sensitive to it. And so the only way you really know is if you give it a try and see if it works for you. And if it doesn't, then I guess it doesn't.
100%. And there's some other techniques like you can actually, if you have a history of trauma or whatever, there's different like cognitive behavioral therapies that trained therapists can work you through. There's hypnosis. There's all different other strategies that you can employ to try to see. And then on the flip side, from my sort of medical hat on and allopathic world, you may benefit from seeing a sleep specialist, a nocturnist. And I am very, very hesitant to have any woman start on any type of pharmaceutical for sleep, because a lot of times these are habit forming and very difficult to de-escalate. But sometimes they are necessary. But a sleep study, you do not have to snore like a freight train to have sleep apnea. And you could be if you are waking up at 2 or 3 a.m. in the morning, and the first thing you need to do is use the restroom, there is a good chance you could be having sleep apnea episode, and working on that. However, there's different ways to do it, and to help with sleep apnea, but just knowing that and be a huge game changer. And then of course, hormones. I mean,
I was going to say, those are coming on.
Hormones, we need to address if perimenopause and menopause, you are having hormonal symptoms, progesterone in particular, but also estrogen, can be incredibly beneficial for sleep.
I love it.
Anecdotally, I've also had some reports of my patients with testosterone helping their sleep as well. It's not approved for that. It's not endorsed for that. But these are all anecdotal. But of course,
I definitely hear it for brain, like just cognition and being more sharp for testosterone. I haven't had any of my patients talk about it for sleep. I think because mainly they're on progesterone at night too. So I think that they're
Yeah.
blaming it on, I mean, in a beautiful way, on the
Yeah.
progesterone and not the testosterone.
Yeah.
It's been hard to kind of weed
it,
that out for mine.
who knows? I mean, it could be that because, we don't study.
We don't know. We don't know what we don't know.
Yeah, I actually just wrote an email. Dr. Mosconi's study that literally was published this week in Nature showing estrogen receptors in the female brain, in a living brain, first of its kind. First study that we've ever seen estrogen receptors in a living woman's brain and what they do pre, peri, and post menopause is fascinating. We've never seen it before. We have nothing on progesterone, nothing on testosterone. So if the test, we know that estrogen is helpful in sleep. It's all part of the hypothalamus, that regulatory center of the brain. But is it because testosterone turns into estrogen and that's why, or is it just
on its own? Yeah.
Yeah, right. But it's kind of like, I don't want to sleep like a baby. I want to sleep like my husband, right? As soon as my husband's head hits the pillow, he's out and twitching, and I'm just sitting there seething.
Be something to that, right? Not the fact that we're just trying to solve all the world's problems and prep for lunch the next day for the kids and all those things. And
I think that that's a large majority. I think the female burden of the weight of the task is a large component. We can control what we can control, and we can add tool to our toolbox. If you just have to kind of work with it, try different things, and see what sort of our tools are going to be best fit for you and your body, because everybody's so different.
Yeah, I do want to steer. I know we're talking about metabolic health. And again, you gave amazing tips. And I think one of those things is just, I always tell women, run those labs, stay on the radar, ask for the more comprehensive cardiovascular panels, looking for looking at a carotid artery score, like just keep advocating for those things as early as your 40s, because it just needs to be on our radar. Ask for the fasting insulin so we can just kind of get a sense of things, but just also know that physiologically your body is going to be changing, and usually metabolic issues are part of that change. So just a consideration. But I do want to move to hormones as well. I know we kind of sauntered into that because of sleep. But they are, as you and I both agree, they are powerful optimizers. Only 6% of women in the US are taking them right now, which is just outrageous.
6% in the US, and I think 13% is the quoted in the UK.
Okay. Yeah. They're definitely ahead of us.
Yeah. But it's
low.
We think so often, we think, oh, it's women, there's been claims that we over medicalize menopause. But 6% of women that are eligible candidates for hormone replacement therapy are currently being prescribed it.
And yet 70% of women, of all Alzheimer patients, are women. 2/3 of people with dementia are women. Bone loss, osteoporosis, women. Autoimmune conditions, 70% are women. More women than men die of cardiovascular disease, and the tide turns at menopause. So we have, where's the elephant in the room? Like, are we really over medicalizing women in menopause? Because we're not winning.
I know it is a travesty. It's something that it really irritates me sometimes, and I sort of have to talk myself off my own ledge, because truly, when I think about this, I don't need to belittle it. I'm like, this is not a difficult concept to understand. We are outliving our ovarian function. There is no other organ system in our body that stops working before and we are able to sort of go on and live without it. And so to just be so presumptuous that women are expected to live a third of their lives without a critical organ system that has widespread effects in every single part of the body. It's unbelievable. This is not hard stuff, people. This is not neurosurgery. This is common sense. The argument is, well, this is the natural part of life. Women are supposed to be living in that. We're the only species other than whales that live a meaningful amount of time in menopause that we know of. Probably the primary reason, and we see this in data trends. I wish I could kind of show you a chart, but there's actually a chart that I showed in showing a lot of the talk, but it actually plots out on a map or on a timeline the years starting at 1800 and beyond, what the average life expectancy of a woman is, and how that has increased and the age of menopause. So how much longer we are living. In the 1900s, the average woman lived no longer than 10 years. Sometimes there's even studies that quote 4 to 5 years in a menopausal state. Now we are living on average 30 years in a menopausal state. So menopause is not a new concept, but the extended duration of life in a menopausal state is very much a new concept. And we are seeing the effects of that, and we are seeing chronic disease and illness. Men still produce testosterone and estrogen well into their late 70s.
Yeah. The disparity, yeah, between our lifespan and our health span is so great. I always think about our menstrual cycle, HPOO axis, as this vital sign. And you know, if we were to have early menopause, no one would hesitate to put us on hormone replacement therapy. Would not. And yet, natural menopause, which to me just happens a little bit later, we're still losing these vital hormones. We're still losing this vital sign. It's just, well, but it's natural here, but it isn't natural 10 years earlier, you know?
Well, the fact of the matter is the larger medical community doesn't hesitate to put women on hormones at any point in their life cycle, starting at puberty up until menopause, until after menopause. We have a 13-year-old that comes in with irregular periods. Boom, put her on a birth control pill. Somebody wants to get pregnant and they're in infertility and they need your bucket loads doses of hormones for you. You know, we do not hesitate to give women hormone therapy to improve the quality of their life or to treat a certain, condition until we get to menopause and perimenopause. And all of a sudden we're like, that's it. Like it's like this boring concept. What are we talking about? And the hormones that we were giving them previously are not even hormones that we use in the hormones that we use in menopause are safer. They are the same hormone as much as we can man-made, a biologically identical equivalent hormone. They are the same thing. So when you take them, your body recognizes them as the same thing that your ovary was producing. So it's a very strange concept to me, especially coming from an OBGYN background, but women's health NP. In all of my teaching, it was never this concept of utilizing hormone therapy in a woman's life was never foreign until menopause.
Or that we wait until ground zero. A whole year needs to go by. I'm like, what?
Absolutely not.
I have Hashimoto's thyroiditis, so I take thyroid medication. And let me tell you, no one ever waited. I never waited until I had 0 T3 or T4 to start getting me to a physiological level. Like that is unheard of, and
endocrinology. Yeah, it is the only endocrine gland that we are like, no, sorry, you're bad, so bad. You can't have this medication, even though we have had estrogen and progestogen. We're close to the 1950s was when the first, Ovarin was introduced, and like these things are not new. We have been studying this. We recognized, that this is important, and for as long as we could figure out how to make them in the lab, we've been doing it. So it's a very frustrating concept from somebody that sort of gets it. And I always say those of us in this space, in this midlife menopause, perimenopause, wellness space, we live in a bubble. We live in our little echo chamber. So we get it, right?
I'm on them. They are God send to me.
I can't go to sleep without my progesterone. I literally laid down last night and stared at the ceiling for 10 minutes. And I was like, you're going to have to get up and get out of bed. Don't take it. There's no way you're falling.
It's at my bedside.
Yeah, I know. I really should move it there. I mean, I have a cup of water there. I should know better. And to your point, and interestingly enough, going back actually to my friend Dr. Mosconi's brain study, what we're actually starting to find, and to your point of the waiting until ground zero, waiting until women are a shell of themselves to finally say, okay, you can have hormones. Okay, you can have this, or telling women if they're on a birth control pill, because that's still the number one most commonly prescribed modality for perimenopause. I'm not knocking it as a whole to be a very effective treatment for a lot of people, but it is not the end all be all for that. And sometimes it frankly doesn't work in perimenopause, a lot of women in perimenopause can have breakthrough symptoms where it doesn't take over. But
Well, yeah, it's not addressing all the things by any means.
Yeah. We wait for women to be debilitated, so much so that the FDA approval on hormone replacement therapy is not just the existence of vasomotor symptoms, hot flashes, and night sweats. We use the terminology bothersome night
It
sweats.
has to have been going on.
What the heck does that even mean? Like, what's bothersome to me may not be bothersome to you, might be bothersome. What are we doing? But
and to your point that the majority of our most disruptive symptoms are brain driven, the mood, the mental challenges, the lack of word recall, like those. And you want to put me on my butt? It was those. I don't have hot flashes. I don't have vasomotor symptoms. I don't have general urinary symptoms. No, I have brain symptoms.
Yeah. Depression, anxiety, low motivation, low mood, all these sort of just, debilitating cognitive symptoms. And so what we're finding and what we're seeing actually in the brain literature is that actually the negative or the deleterious effects of the brain that lead to dementia actually start in perimenopause.
Yeah.
So it actually, Dr. Mosconi says dementia is actually a disease of midlife, but it's manifested in late life. And so therefore, we actually need to shift the paradigm in how we treat women. And instead of waiting for things to be so bad that now we can validate or, we put them on something, maybe we actually intervene right as something starts to happen. And, I started hormone replacement therapy in the form of micronized progesterone when I was 37 years old. The only reason I started on it or was able to start on it is because I'm a women's health nurse practitioner. And I knew when I was having night sweats every single night and not sleeping, it was perimenopause. And I knew. But the vast majority of 37-year-olds have no clue.
Or even if they were having those symptoms and they went to their primary, it would be a no-go.
It would be a total no-go. It would be gaslight. You are too young. Your labs are normal. This ridiculous notion that we can use labs to invalidate somebody's symptoms. So again, it's a challenge for sure.
Yeah, I agree. And you were talking about, until we're a shell of our former selves, but I would say even by menopause, for so many, we've been a shell for a while, and so I am a big proponent again of supplementing hormones in perimenopause like you. The second that these start to shift, like that's the time. These are symptoms and disruptive symptoms, at least for me, they were.
Yeah. Well, and if we're worried about the risks versus the benefits of hormone therapy, I mean, the risks of being on an oral contraceptive in your 40s is far, far beyond. Micronized progesterone is over the counter in France and several other countries. I mean, there's almost God forbid I go out on a limb here and say risks associated with it. Some people can't tolerate it because of certain side effects, but in terms of, risk, it's really an incredibly safe medication. I mean, it's certainly safer than Tylenol.
Yeah. It's phenomenal.
And it is. So
yeah, go on.
Sorry, I didn't mean to interrupt you. Go ahead.
I was going to say, I had, as I mentioned, I had a brain injury last summer and it was a part of my concussion protocol. Like, progesterone is allopregnanolone in the brain. It is an anti-inflammatory for the brain. And so I just want to speak into that, I started it well before the brain injury, but I was on continuous use during my brain protocol. I'm back to cycling it, but specifically to reduce the amount of inflammation due to the trauma that my brain had.
Yeah, there's tons of data out there on TBI and utilizing that. It's so fascinating that you said. I mean, that's a whole sort of
whole nother
issue itself. Yeah, but I think it's really important. We talked about this actually before, pre-show recording, but it's really important to also understand that hormone replacement therapy. There are certain individuals that don't do well on hormone replacement therapy, or cannot, or do not want to take hormone replacement therapy for any reason. And a lot of times, I think that these women do. I don't want to downplay the benefits of hormone therapy because it is life-changing for so many, but I do understand it's hard to be in the group that either cannot or doesn't want to. It sort of feels like there's a party going on and you're not invited to it. But hormone replacement therapy is not a panacea. So going back to kind of the earlier parts of our discussion, it is really important for women to, take their health into their own hands and really start implementing some foundational pillars of health in midlife and focusing on themselves, such as sleep and nutrition, quality movement, stress reduction, things that you can control to the best of your abilities. Because, I kind of say, think of midlife like you're about to, be Tom Hanks on Castaway. You're about to be deserted on a desert island. If you had, 10 items that you got to choose to take with you on a desert island to improve your chances of, survival or making it easier on you, what are you going to take? Hormone replacement therapy is one tool, one that's going to be correct. It's not going to be the sole reason why somebody, lives longer than another or has, there is a whole plethora of things that somebody needs to do in order to best optimize their health and wellness going forward. And hormone therapy is one thing, but it is not a panacea. It does not cure everything that ails someone. It is a tool, a great one at that, but it is one tool. I think it's really important to stress that.
Agreed. And like you said, some of us are, for whatever reason, phenotypes, genetics, epigenetics, bloating, bleeding, mood swings, like things we may be too sensitive to it, whether it's estradiol or progesterone or even testosterone, and I think there's no one size fits all. We kind of got to figure it out for each one of us, kind of how to dose that and create, kind of a Goldilocks, solution for ourselves as well. But you're right. I think, if we've got a bad gut microbiome, if we've got a lot of unprocessed trauma and a sympathetic nervous system that's completely whacked out, and we are staying up way too late, like these are the things that are gonna, kind of unfortunately, mess with our vitality and our health span.
100%. Estradiol has been shown to decrease, coronary heart disease by some accounts up to 50%. But if you are eating processed food and fast food and inflammatory diet and you are sitting and not moving and your entire life, that your risk reduction is probably not going to be as good as somebody that is working on the fundamental pillars of health and trying to do the best that they can with what they have. So again, it's important to really sort of look at things holistically rather than just sort of like go down the hormone train is going to fix everything. Because I do think sometimes that narrative is put out there and it's misunderstood.
Agreed. And I think, again, with only 6% of us here in this country, I get why we're shouting from the rooftop. And the research is so clear. And that's why I say it's a yes and. Yes. And we need to take all these other things into account as well. Jackie, can I ask more on a personal note, what would be some non-negotiables for you? As you just navigate your journey, like, if you were Tom Hanks on the island, what would be your non-negotiables?
Yeah, I know. Like a machete. No, I just, that's
could be on your list.
So, yeah. So I definitely am very open and transparent about this. I will definitely be utilizing hormone replacement therapy as long as nothing changes in my health between now and menopause. And as long as there's no massive changes in the data that we have, I currently am in perimenopause, so I use progesterone currently. I don't have a need for estrogen in the moment or testosterone, but I will be exploring those most likely. I think that protein is a non-negotiable. I try to hit protein goals every day. I am a big yogi, so that is a non-negotiable for me because that hits multiple areas of health and wellness for me. It keeps me sane, and so it helps as a stress reducer for me, and it also is a good form of physical fitness. So that is a big one. I also do meditation and mindfulness, and I practice gratitude, which I find abundantly helpful. To practice gratitude and like I said before, sleep. Although I'm not always the best at it, but I am a good trier and I try hard every single time. And here's a good one, because this one we find in individuals that live the longest and certain populations that have the highest percentages of older individuals is community. Yeah, sense of community and relationships. And I think oftentimes in a world of social media and our phones and this sort of false sense of community, we really have to step away from that and get back to sort of what life was like before that. So, and we see that in the most well-lived and longest-lived population, they have a strong sense of community and relationships.
Yeah, and that was one of the things I was like with the Tom Hanks top 10 list. I'm like, can I just bring all my besties? Like, did they?
Yeah, all my friends.
Obviously, my friends. Oxytocin, please.
Yeah, so it's really not. And here's another one, and this might be strange, but I am non-negotiable to have an abundant sex life as I get older. And I think that a lot of women, and it's a form of exercise, it's a form of oxytocin, it's a form of all the things. And I think so many women sort of and sexual medicine is one of my practice areas of focus, menopause, midlife, but I also do with complex sexual medicine disorders as well. And I think a lot of women sort of get this sort of passed off like out to pasture, like you know, you're done and you're retired and you shouldn't have any need for this. I just think that's a load of BS, excuse me. And I think women should be able to have a vibrant, active, healthy life. And I think that the sex life should be a part of that.
Those are great.
Yeah.
I love those. Our boundaries one.
Oh my God. Boundaries, an elusive thing. I am terrible at boundaries. I will just tell you that. It's probably something I need to like write in lipstick on my mirror. You know, like those techniques of like putting those affirmations on your mirror that although affirmations are a good one too. They're a form of gratitude. Boundaries are something that I have actually had to work on. I've had some personal trauma in my personal life. I lost my sister when she was very young, and so I've had to work on boundaries. Our whole family has had to work on boundaries because that's sort of what happens when you go through that. The boundaries in my professional life too. You know, I'm a workaholic, and you know, oftentimes my husband or my kids will even say, "Mom, put it down, put it away." It's really difficult.
That's trauma as well, I'm sure.
100%. It's so easy to dive into things that are not emotionally relevant for you or are less emotionally charged, right?
That are mission driven.
Yeah, 100%.
Yeah, it's my mission. It's my purpose. I mean, obviously.
Yeah, oh my God. We are sometimes our own worst enemies. I will say that. I am definitely. But I mean, boundaries. I talk about this a lot with my patients because midlife and menopause is, and oftentimes the Gen Xers, who are the vast majority of the women that are currently going through midlife and menopause right now, just generally speaking, are sandwiched between their teenager and young adult children that are still children and their elderly parents who did not have a good menopause journey and are suffering from chronic disease and illness. And it's a huge burden. And
also hard. Don't have boundaries.
Great. Jaclyn have trauma and toxicity and all sorts of things that we could do a million other podcasts about. But 100%. First of all, I find it most useful to call a spade a spade. The thing don't have, you know, just let's work on it because it's, like I say, it's an ever-elusive thing. Like it's really hard to have boundaries, and you have to, like muscle, it's earned. Boundaries are worked for and constantly. Oh yeah.
I'm calling myself the Queen of Hearts these days. Off with their heads.
My gosh, ruthless. That I guess you know what? Nobody's gonna fight for you. You have to fight. You know, you have to fight for yourself. And hey, I'm all for it. I think that's great.
I'm the bestie who's like, wait, what? They did what? Oh, this is what we're going to do. I'm giving you full permission to shut it down. I'm the friend advocating hard. Because, yeah, I mean, I grew up boundaryless and trauma. And gosh, everything's up for review in this time. So, yeah, man, my walls went up hard. A lot of therapy to get me there. But I was curious where you landed on that.
Yeah, it's a learn. Skill. It does not come naturally. And I'm not always like sometimes my husband will get me on the phone with my mom and I just see these looks and he's just like, you know, giving me these eyes and I know 100% he's standing there listening to the boundary alarm is going off and it's not being exercised. So it's really hard. You know, it's really hard because we want to care for those that we love. And it's so much easier to put others' oxygen mask on before your own. You know, whether that goes to our parents or our children or others, it's easier to sort of direct our energy outward, I think, sometimes than it is inward.
Yeah. And you're a healer. You're an
Yeah.
amazing healer. And you think about healers and how giving they are. I find healers in particular, this is what we do. It's literally what we do. We hold space for everybody else. I just want to say thank you so much for fighting the fight and for being there and for holding space. Thank you for coming on, Jackie.
Of course. Thank you so much for having me. It has been a pleasure. I really appreciate it.
Me too.